Welcome to CSAP 18 Audio Companion. Today, I am pleased to have Dr. Charlotte Gale Patterson as my guest CSAP author. Charlotte Gale, could you offer our listening audience a little information about yourself, including where your practice is located and how you spend most of your time in the practice of surgery?
Thank you for having me included on this audio companion. It's exciting to see these revived and do it again. I am in private practice in Naples, Florida. I am a 100% dedicated breast surgeon. All of my practice has been breast for over 10 years. I'm raising my three crazy little girls here in Florida, and in between hurricanes, we try to just do stuff as a family and be surgeons.
Sounds great. And I thank you very much for agreeing to do this. And I've asked you to participate in our discussion today, obviously regarding breast topics that are found in CSAP 18. So let's get right at it. A number of CSAP questions in 18 focus on the workup of a patient with a breast mass. And let's talk about a 25-year-old who presents with a new unilateral, tender, palpable breast mass. Where do you start your workup?
This is indeed a common problem, and it's one that almost all general surgeons are going to be asked at some point in their career to render an opinion. In a premenopausal woman of this age at 25, the chances of the breast mass being a cancer or malignancy are low, but we still need to be very thoughtful and complete the appropriate workup. So the first step after a complete history and physical examination would be to do, either in the office or order, a focused breast ultrasound. So all women under the age of 30 that present with a breast mass, the first imaging study that you would like to get would be an ultrasound.
Well, we're going to talk a lot about ultrasound, I believe, but let's just start with this ultrasound in this 25-year-old shows a cystic mass. What do I need to know about that?
And I agree that we're going to talk a lot about ultrasound with breast conditions because it's a very easy study that's readily available and it gives us so much information. So when you have a patient that shows a cystic lesion on an ultrasound, it's basically just telling you that there is a fluid-filled structure. Cystic lesions are usually found. They're a result of dilated terminal ductal lobular units, and most commonly it's from fibrocystic change. The ultrasound report, the words that you would be looking for is anechoic structure, which means no echo. If you actually looked at the ultrasound yourself, you would see a black circle. Ultrasound is using sound waves, and so those sound waves are going to move through structures, and sound will move faster through water or liquid. So you'll see something that we call posterior attenuation or increase through transmission. What this means is that when you look at the ultrasound, you're going to see that black bubble or that black circle, and behind it, you will see bright white posterior to that cystic structure. And this is very diagnostic for a cyst. And with a cyst, it's very important that we define what a simple cyst is. The criteria of a simple cyst, there are 5 criteria that must be met. The thickness of the wall must be less than 0.5 millimeters. It should be anechoic in the echogenicity, which we mentioned earlier, and distal enhancement, which we talked about earlier. The margins should be very well circumscribed with a round or oval shape. And you should have an outer capsule around it with a thin acoustic edge or shadows, which is black. So these are all benign. And when you see this, even though it can be very large, these are all benign. And so you can assure your patients that this is not a cancerous process.
Is it still okay with this to aspirate this and see if it goes away when you follow the patient?
It is. We treat cysts based on their symptoms. Because we know that it's not a cancer process, we aren't trying to prevent a problem. So if the patient is having a problem, you want to treat that problem. The most common problems are going to be pain. So if the patient is able to localize with their finger that one spot causing pain, it's very likely that aspirating that cyst, they're going to get relief. Sometimes large cysts in very immunocompromised women can have some kind of bacteria that accumulate in there, and those will turn into an abscess. And so again, if you're seeing a very red, hot, inflamed cyst, aim the treatment at that problem and drain that fluid out.
What if that mass is solid? I'm sure we must take some different steps.
Yes, if it's a solid mass, and if we go back to our woman being a premenopausal age and she's 25 years old, your differential diagnosis is going to include benign lesions like a fibroadenoma, a phylloides tumor, other adenomas like tubular adenomas. But a solid mass, you cannot say with certainty, like you can with the cystic mass, that this is not a cancer and you're going to have to go for further workup.
And does that workup step up to mammography at that time, or do we go right to some kind of invasive test to obtain a biopsy?
Right. If they're under the age of 30, we still say an ultrasound guided biopsy is appropriate. Ultrasounds really advanced our ability to detect these lesions in women with dense breast tissue. There is absolutely no radiation with an ultrasound. And, in this premenopausal population, you are dealing with women that may be pregnant and not know it. So minimizing radiation would be clear. And you can see much better in the dense breast tissue with an ultrasound. But if you do happen to do an ultrasound and find a solid mass, at the same time, you have the ability to use that ultrasound, look in the axilla in what we call an axillary sweep, and then get an idea about the lymph nodes so that if this does turn out to be a malignant process, you've already started the staging process.
Let me share with you an experience I had with CSAP-17 with a question, and it related to a young lady, I believe it was 35 years old, and they presented with a new palpable breast mass that was tender. And we indicated that the correct thing was to start with an ultrasound. And if the ultrasound showed a solid mass, we went on to get a mammogram. And I caught all sorts of comments from users to say that we should never have gotten the ultrasound, we should have just gotten a mammogram because she's 35 years old. And you've mentioned over 30. Is that an absolute rule that you guys follow?
It's not. And it's very common that I'll see a young woman come in her 20s and she's had a mammogram and, I just hold my breath and kind of move on. But there's no official consensus, but there is kind of a common sense consensus. The younger you are, the more dense your breast tissue is going to be. Density is very difficult. A mammogram is like shining a flashlight through tissue. So the more dense it is, things are going to hide. And there is a radiation exposure. And I don't think that we can just ignore that. It's low and we encourage patients to get it because it's low. But any radiation exposure we can avoid is what we want to do. 30 is kind of that rule. So 30 to 35, it's, dealer's choice. 35 and above is reasonable to start with a diagnostic mammogram. But a woman in her 20s really should not have a mammogram as their first choice.
Well, we're going to talk about mammograms too, but I want to get some nomenclature straight too, because it seems to be getting more complicated rather than less complicated.
It's a new language that you have to learn.
Yes. And so can you help me through this 2D, 3D, tomosynthesis, digital breast exam, and give us a brief synopsis of what all this means today?
Yeah. And if it's confusing for us, can you imagine our patients that have other daytime, full-time jobs and none of the advantages and benefits we do of studying this all day and still being confused? So it causes a lot of confusion. But we used to have film mammography, which is really not available in the United States much anymore. So all of the mammograms are going to be digital. I think that there are some facilities that will still actually print out the images, but it's still not film mammo. It's a digital mammogram. And so 2D just implies that there's 2 dimensions. So the patient will get the standard 2 views, the CC cranial caudal, which is just top to bottom, and then the MLO or medial lateral oblique, which is just kind of looking from the medial to the lateral in an oblique manner, trying to get into that axillary tail. 2Ds are the standard. 3D is the same as tomosynthesis, digital tomosynthesis. 3D mammogram is tomosynthesis, and it's kind of the newest addition and newest tool we have in mammography. I would suggest that it's almost universally available in the United States, but I don't know that every nook and cranny has adopted it. And having a 3D mammogram is not really something that a patient is going to notice on the machine. And Dr. Weigelt, if you and I walked into a mammography suite, we would be hard pressed to say if it was a 2D or a 3D machine, because it's really in the imaging software and the rendering of the images. A 2D machine can have software installed where you flip a switch, and then those pictures will then be 3D. The same switch can be turned off on the same machine, and then you get a 2D image. So you get these images like a CT scan or an MRI where you can really scroll through them. So 3D tomosynthesis, those are interchangeable words, but do create a lot of stress and anxiety for all of us, really.
Okay. Well, let's talk a little bit about how the reports come out now. And obviously, we need to talk about the BI-RADS system. Now, the BI-RADS is applied to both ultrasonography and mammography. Is that true?
It is, and also breast MRIs. So they've really put it across all of breast imaging. And even though my world is in breast, I have seen reports come over. And so I know that our thoracic colleagues and pulmonary colleagues now have a LRADS or a lung RADS, where they're looking at pulmonary nodules. So, BI-RADS started in 1993, and I think that the rest of the, organ systems are starting to catch up.
When we're talking about the BI-RADS system, there are essentially 7 categories. Is that correct?
There are. And of note, it's worldwide that we use the BI-RADS. But even worldwide, there's the American and then European. There are a little bit of variances, but a BI-RADS 0 in France is the same as a BI-RADS 0 in New Orleans. They mean the same thing.
And they not only help identify what the radiologic findings are, but it also helps make clinical decisions, correct?
It does. It's a real uniform way to communicate. And if you think about what a mammogram's job is to tell us, based on this picture, be it ultrasound, be it mammogram, be it MRI, what is the chance that what we're seeing in those pictures could be a breast cancer? And so these 7 categories are statistically divided. Based on what I see here, there is a blank % that this could be cancer. And so as surgeons, primary cares, and other doctors, those BI-RADS are what are telling us. The radiologist is telling you, I think this is fine, or I'm really worried about this. And then we understand and we know what we should do next based on that category.
Okay, now we talk a lot about, or I would defer to you, Charlotte Gale, and your breast colleagues who have been with me on CSAP. And you talk a lot about concordance of biopsy and radiographic findings. And obviously the concordance means that they correlate with one another. Are we closer to having the idea that you can make a diagnosis of breast cancer without a biopsy using mammographic evaluation?
We're getting closer, but rest assured the surgeons will still have a role in confirming that there is breast cancer. The biopsies that come back with no cancer are the ones that keep me up at night. And it's for the reason that you say is concordance. It's entirely possible that the needle wasn't exactly in the right spot or the patient moved. And, we're talking about millimeters of difference here. If you get a positive result, I think we're all fairly confident that we know what to do with that. But the concordance process is huge and is key. And so for any ACR or American College of Radiology accredited facility, that is a requirement that they do concordance. So the radiologist will perform the procedure, whatever it is, image guided, and then have the pathology, and they will render at the end of their report a concordance. It's either concordant, which means I looked at the pictures, I looked at the path, and yes, this makes sense, I agree. Or discordance means I looked at both of those and this doesn't make sense. There's something else there that we're just not getting. And in those situations, either more imaging or another biopsy or surgery, would be necessary.
Now, the other thing I want to mention before we leave this BI-RAD system is something that's been added since CSAP 17 was produced and now appears in CSAP 18, and that is measurement of breast density within the BI-RAD system. Can you explain what that is and why that's become so important?
Breast density, it's a measurement of the fat to the glandular breast tissue ratio. I kind of bluntly tell my patients that when you are young and you're 18 and not required to wear supportive structures that you could buy at the department store, it's because you have very dense breast tissue and very little fat. As the breast does its job through reproductive years and then you go through menopause, that breast tissue will involute and become fatty tissue. And that fatty tissue requires a little bit more support, and you'll spend a little bit more money at the department store buying things to keep them back up where they were. But as that fat content increases and that dense breast tissue decreases, your density is less. And so again, if you think about shining a flashlight through some substance, the dense breast tissue is very thick and the fatty tissue, it shines right through. So it was in the 90s that one of the states passed a breast density legislature, and it was requiring that every mammogram tell the woman what her density is, because dense breast tissue is a risk factor for breast cancer, partly because the mammogram can be difficult to read. And so it became a patient right issue. So the women were all notified at the bottom of their report, you have dense breast tissue. This is an increased risk for breast cancer. Talk to your doctor about what else you could do. Florida has adopted that now, and so the patients are reading this and they know that they have dense breast tissue, and that prompts a lot of referrals to breast surgeons and talking about risk reduction and what do we do. So the density, as state by state is passing these laws, you're going to see a whole lot more of this being referred over to you, because the primary care or even our referring providers are just going to say, I don't know how to advise them on this density. So I think as a general surgeon, we're going to see a lot more patients wondering about their density because it's going to be on every single report that they receive. Okay.
The other discussion we had in CSAP 18 committees is, okay, so you have a woman with dense breasts, and the mammography technique of choice, is that always a 3D, or what's, I guess the other word that's used is tomosynthesis? Is that true then?
It is. The tomosynthesis is the most helpful because it's 3D, and so it's like a CAT scan. You can see through all of that white that you've shined your flashlight through. Instead of just seeing that one picture, you can, and you get them in both views, so you can kind of three-dimensionally recreate all those islands of glandular tissue. So having 3D it significantly decreases the callback rate, which means I saw something on your mammogram, we're going to bring you back for an ultrasound and a mammogram, but the 3D really, really cuts through the need because it can see so well, what's going on there. That 3D software is so helpful.
Well, let's go ahead and let's talk about a few patients. Let's go back to that young female with a breast mass. It's round, it's discrete on physical exam. The ultrasound is also round with smooth margins, and it's called a fibroadenoma. is there any reason to pursue a tissue diagnosis at that time?
This comes up frequently, and it that's why you're asking. Based on her age, again, at the age of 25, it's likely going to be a fibroadenoma. But fibroadenomas live underneath this umbrella category of fibroepithelial lesions. And a majority of those fibroepithelial lesions are going to be fibroadenomas. But the minority of these can be a very aggressive process, something called a cystosarcoma phylloides tumor. And while they're rare, I don't think that you can just say because it's rare, we're not going to, address it. So under the age of 18, there is no mandate for an image-guided biopsy prior to a surgical procedure. Having 3 little girls in my house under the age of 18, I know that I wouldn't be able to convince them to sit still, put a big needle in a delicate and sensitive area and just say, quit moving. But over the age of 18, the official recommendations are to offer or consider a needle biopsy. Now, I think as surgeons, we understand recommendations, but we also have some discretion. So common things being common, you really wouldn't be faulted to remove that. But something that you have to be cautious about is depending on how young the woman is, you really have to make sure that these smooth, mobile, disc-like structures may be underneath the areola are not actually a developing breast bud, because taking that out will have ramifications far down the road.
So with that 18-year-old threshold, is the choice and the risk of injuring the breast growth, is the choice to get a biopsy rather than an excision?
If you're sure that it's not a breast bud, I only bring it up because I've seen it, If you're sure that it's not a breast bud, and so work closely with your radiologist, look at that image and make sure it's not. Under the age of 18, standard would be to take it out and remove it for the patient.
All right. Well, what if you follow it? And we've got one question where fibroadenoma is being followed, and the next ultrasound exam shows that it's doubled in size over a 6 to 12 month period. Would that be disturbing to you?
That would get your attention for sure. We have the Choosing Wisely campaigns, and because fibroadenomas are so frequently removed, the natural history of a fibroadenoma is that 85% are going to disintegrate, dissolve, and just kind of go away, involute on themselves, kind of hyalinization. 10% will just die and be kind of dormant, hanging out there. They don't grow, they don't go away, they're there. But 5% are very, very hormonally responsive and very reactive. And you will see that 5%, those will grow, and it's not a subtle growth. You can usually tell on physical exam, and you will see that it grows on your imaging if you're doing imaging follow-up. And we call those juvenile giant fibroadenomas. So the Choosing Wisely campaign is really just to take these out if they're cosmetically sensitive, so symptomatic or causing pain, if it's larger than 3 centimeters, or if you do see that rapid growth. Because rapid growth could also be the rare fibroepithelial lesion of a phylloides tumor. And so removing that would be important.
And if your imaging is suspicious for a phylloides tumor, do you biopsy that before excision?
So that's tricky because fibroadenomas and phylloides can look exactly the same on the ultrasound. Even pathologists, depending on the core of the biopsy, the needle size that they're using, there are some that will say, I can classify this as a fibroepithelial lesion, but I defer to excision for final diagnosis. So because of that broad umbrella of fibroepithelial lesions, a fibroadenoma and a phylloides may look just the same on ultrasound. They may feel the same on physical exam. And even your core biopsy can throw off a very, very experienced, seasoned, competent, fellowship-trained breast pathologist that you can't be confident it is or isn't a phylloides.
Okay, well, you decide to go ahead with excision, and the final path is a phylloides. Are all of them malignant?
They're not. Again, they're very rare and they can be hard to differentiate on a core biopsy. But the classification of the phylloides are either going to be benign, borderline, or malignant. We used to just say benign or malignant, but we now have this borderline there in the middle, just to make it more straightforward. And the pathologists base this classification on the stromal cellularity, overgrowth, the tumor borders, which they would have to have excision, not on a biopsy, number of mitoses, and necrosis, because if they're outgrowing their blood supply, you'll see some necrosis. And phylloides really behave similar to sarcoma tumors. And so, like a sarcoma, they have a high risk for local recurrence, and they will spread hematogenously to the lungs and the liver and the bone, and not through the lymphatic system. So if you have a phylloides, local recurrence being your biggest concern, resection margins are going to be key. For the malignant phylloides tumors, we used to check the c-KIT, and if the c-KIT was elevated, we would give the imatinib therapy, but that's fallen out of favor. So for the malignants, it's still surgical resection is the mainstay with a good margin.
And the good margin is 1 centimeter?
It used to be a centimeter. We would say wide local excision, and I remember training as a resident, they would say 2 centimeters, and then I thought, we're going to run out of breast tissue in here in this way, And so I think other people had a similar idea. And I've seen some women 20 and 25 years after a phylloides and, they had a mastectomy. So that was the prevailing idea, is that we had to get wide margins. The 1 centimeter margin was smaller studies, because this is an uncommon tumor. And so the N, was not large on people that we could study. But what we know now is that 3 millimeters is sufficient for a malignant phylloides tumor. Looking at greater than 8, you didn't get any better survival than somebody that had 3 to 7. So getting 3 millimeters of a margin is improved in metastasis-free survival, decreased local recurrence. So 3 millimeters is what we recommend, and that's the current guidelines.
That's a major difference than 1 centimeter.
It really is. I mean, that's a third of that.
Yeah. Okay, well, let's raise the age of our patient to a 35-year-old, and she presents with nipple discharge. And can the type of nipple discharge really dictate how your workup proceeds?
Absolutely. If you think about the structure of what the nipple is, nipple discharge becomes a little bit more straightforward, I think. The nipple is a raised structure where all of the ducts are going to terminate, because those are your transport systems for fluid to come out, milk if you're having a baby, and then other secretions. So if you look down the top of a nipple from the top, there's 7 to 11 little orifices or sinuses that are what the fluid would come out in a woman who's lactating. Because those are ducts, very similar to your lacrimal ducts, your ears, your nose, all of these ducts, there's going to be secretions and mucus and gunk that can kind of come in and come out. So understanding whether or not it is spontaneous or non-spontaneous, which means the patient is squeezing on it, is a huge distinction to make. Somebody that is stimulating their nipple and trying to squeeze out the pus, and I've had patients with clinics that they've saved and pictures of the stuff they've squeezed out, very different than spontaneous discharge. Spontaneous is going to be pathologic, and that's a problem. Non-spontaneous is physiologic, and it's either, something that they're doing or something else that is not a surgical problem. But then within that spontaneous, is it one side? And if it's one side, is it one duct or is it all of the ducts? So understanding the type of discharge. If it's one duct, so when you examine the patient and you see one dot of fluid, be it bloody, non-bloody, you know that it's something isolated to that one duct. If it's diffusely coming out, either that side or the other side, that's going to be more of a physiologic process, and it's either going to be something in their endocrine system, checking a prolactin, or their thyroid function axis that non-surgical is going to be more likely to be that.
Then there's a couple of questions about the various types of imaging that can be used to evaluate a patient with nipple discharge. Is there really a preferred, or is that a very individual decision made by the surgeon and the patient?
It's going to be individualized, but a diagnostic mammogram and ultrasound are a good first step. If within the last 6 months they've had a mammogram and it was normal, you can escalate and go to other imaging studies. But a diagnostic mammogram and an ultrasound are still going to be your first choice in looking what's going on. It's usually sufficient to find what you need, but the most common cause of spontaneous bloody nipple discharge isolated to one duct is going to be an intraductal papilloma. And these things are very tiny. So sometimes if the duct is not dilated enough, it will compress on the mammogram and you won't be able to see it on the ultrasound. So sometimes it's not sufficient, and the mammogram and ultrasound just aren't going to be enough. And these papillomas are not always going to be central. They can be distant, more further down in the ductal system.
In that single duct nipple discharge, is ductoscopy still helpful, or has it fallen out of favor as imaging has gotten better?
I remember seeing the videos of ductoscopy, and it's really amazing. These tiny little cameras that can go in and you can explore that duct. I've never got my hands on a ductoscope. I guess that's how you would say it. And I've never known anybody to personally do it. It's just at the meetings of, look what I can do. But I remember one of the talks about ductoscopy was that the specimens that they were taking were so small that they would see the papilloma on the images, magnified on the TV. They knew that they had got it in their little snare and pulled it out. But then when it came to pathology and they cut their blocks, they just said there was nothing there because it's so minute and tiny. So ductoscopy is interesting, and I'd be interested to see if it continues. But ductograms are still used, which is you cannulate with a little plastic, cannula, and then inject some contrast into that duct and take a mammogram.
And that is still commonly used?
No. Yeah, it's your answer on some of these examinations. It's a reasonable approach, but in the real world, they fail frequently, up to about a quarter of the time. It's difficult to sit still. Again, what has to happen is you insert this little plastic tube into the nipple, and then you're going to inject some contrast. So if it's a very centrally located obstruction, then the contrast kind of spills out. Getting that nice filling defect can be difficult. So while it still is helpful, and I've ordered a few, fewer than the few have resulted back in something that helped me.
And we always talk about the papillomas, which you've already mentioned. Is there really any worry about cancer in these lesions?
There can be, yeah. So the papillomas are going to be your most common cause, and that's what we expect to find, and those can be hard. So, back to if the ductoscopy doesn't work, we can do an MRI, and the MRIs are pretty sensitive and can have a higher negative predictive value than the ductography, because I think you get it done, you can see, but it lets you look at the rest of the breast too. And with a ductogram, all you're really going to see is the anatomy of that duct. What the MRI will show you is, does that ductal lesion, does it look like it's extending from something into the duct or from the duct into something else? Because you can have invasive lesions that are just kind of chewing into the duct, and that's what's causing the discharge, and that's what's causing the bleeding. And it would cause a filling defect on a ductogram, but the MRI would give you more background area on the, what else is going on around that area. And so when our papillomas are red on pathology, we're always looking to see whether or not there's any atypia within those. So if there's atypical hyperplasia associated with or within the papilloma, then those are going to have a higher risk of upgrading on excisional biopsy. The studies of what the upgrade rates are all over the place depending on the gauge of the needle and whether or not that institution routinely removed all the papillomas versus the ones that had a higher chance of being a cancer anyway, which, kind of skews the numbers.
When you have that upgrade and you have a papilloma, how do you establish your margins for appropriate excision?
If you've taken the papilloma out and you happen to find breast cancer, we're still going to go, every lesion you take out of the breast, you should orient with margins. If we remove something from the breast, we always place orienting sutures. So commonly we'll say short superior, long lateral, and that allows the pathologist to evaluate all 6 sides of the tumor, the anterior, the posterior, the medial, the lateral, and the inferior and the superior. So your pathologist is going to look at those margins when you get that report. It's either going to be an in situ cancer or an invasive cancer, and the rule still applies. Invasive cancer, a negative margin is tumor touching ink, and in situ is at least 1 with preferably 2 millimeters. So when you remove the papilloma, I place a surgical clip so I know where it was, and then the pathologist will tell me your margins are clear or this one is close. And then I do go back and re-excise. And if there's invasive, depending on the age and the size, they may be a candidate for a sentinel lymph node biopsy as well.
Well, let's go on to another topic, which I have learned from you and your colleagues is a common problem that is vexing you and the patient.
Breast pain.
Yes. How did you guess?
Yes.
And believe it or not, I've looked back over the last 3 CSAP editions. The questions stay the same, but the answers keep changing. So let's walk through a patient, and maybe you can bring us up to today's recommendations. So a woman presents with breast pain that has been getting worse over the last year. Analgesics do not seem to help anymore. She has a history of fibrocystic disease, and her breast pain is bilateral, and there is no nipple discharge. Where do you start?
This is another common non-surgical complaint that every general surgeon is going to see frequently. Because fibrocystic changes are a normal process of breast changes, I really redirect the narrative with the patient that fibrocystic is not a disease, it's a process. I have it, you have it, whoever else in the room I can point to, we all have fibrocystic changes. And taking that label of disease off can help get us in the right frame of mind, a perception of how we're going to fix this or make this better. Understanding that it's normal is helpful. Pain is associated with this fibrocystic change of the breast, and you'll have the cystic areas, and you can feel those as tender, well-defined lumps, like we talked about earlier with cysts. And then the fibrosis part of fibrocystic is these small little areas of fibrous epithelial tissue. You can feel them as just little firm, lumpy, bumpy, kind of not a dominant nodule, but just lumpy. Getting the patient's history, taking the time to talk to them is important for this difficult, vexing problem. So trying to figure out what makes it better and what makes it worse is hard. Women who have had a hysterectomy and still have ovaries that are intact, or maybe had a uterine ablation, or for whatever reason they don't have their periods, really aren't in tune to the cyclic changes of when they would be ovulating. And those cyclic changes can give you a clue to the nature that this is hormonal changes, it's fibrocystic changes. My doing something surgically is not going to help because this is within the realm of normal hormone changes. And then the location, you gave us a big clue on the location. If it's bilateral and diffuse, it's not going to be a surgical problem. Localized, consistent pain, one spot, always point to it. This could be from something like a cyst, which we could aspirate. And commonly, most breast cancers don't hurt, but it could be a tumor. I have patients with breast cancer that will anecdotally say, that breast has always hurt me. And okay, But pain is not really something that tunes you in to say this is likely a breast cancer. But it's so common that it's going to plop into your office, and that's what everybody wants to know, is that they don't have breast cancer.
And is imaging helpful in the patient with mastodynia?
It is. We're going to again start with that diagnostic mammogram. Ultrasound can be useful if you've got focal pain, but if you've got diffuse pain on both sides, ultrasound's really not going to add a whole lot to that. Diffuse pain is going to be a systemic and not an anatomic process. So an ultrasound is going to be unlikely to really find anything. And, the goal of your imaging is to rule out something anatomic, because as a surgeon, that's what we can take care of, are anatomic things that we can remove or modify and take out. If it's a systemic problem, then endocrinology or gynecology consultations to help you out would be appropriate. But interestingly, and there was some data presented years ago that referred pain from your shoulder is a really underappreciated cause of breast pain. Shoulder injury, shoulder pain, limited range of motion on exam. Your brain is feeling pain in that region, and so that nerve bundle is kind of mixed up, and your brain thinks your breast hurt. And this study was, they did injections in the shoulder and the breast pain got better, which just tells us it was likely a referred pain and not really just the breast. So being mindful to shoulder injuries, shoulder problems, and just not having the narrow side of just looking at the breast can hurt for other reasons.
Okay, well, let's cut to the chase and say that mastodynia is your final diagnosis. And when I look back on CSAP suggestions, we've had nutritional suggestions, we've had herbal suggestions, we've had local care suggestions, and drug therapy. So is there a escalating treatment paradigm for this, or tell us what you do?
It's a complicated, escalating, multidisciplinary approach. In the back of your mind, you need to remember to help the patient align their expectations with realistic outcomes. It's not going to instantly get better. And there's some cases where everything we do is not getting better, and then they're diagnosed with fibromyalgia or another chronic pain syndrome. So I don't hesitate to involve pain management if it's really something that I'm struggling with. But I don't start there. Like you said, it isn't escalating. The most common thing that helps if a patient is able to do it is to decrease their fat intake. So a low-fat diet does decrease mastodynia and breast pain. It's easier said than done, a healthy diet and a healthy exercise. But some of the supplements we've talked about, the flaxseed, the omega-3 fatty acids, chasteberry, gamma-linolenic acid, and iodine supplementation, selenium, a lot of those have kind of said this probably works. Iodine level is something that I do check in these patients, and I have found a few iodine deficient patients that giving them iodine supplementation or showing them high iodine containing foods gets it back up. It used to be in this civilized world that iodine wasn't an issue because we put iodine in our salt so that people weren't getting goiters. But then we got fancy and smart. And so we got these like sea salts and these pink salts and the Himalayan salts. And, not all of those are iodinated. So you take for granted what has been, available to us. And so I've found a few low iodine and we supplement and they do feel better. I have had great success with getting them in a properly fitting bra and understanding how your bra helps you and how your bra fits. It's not supposed to hold all of the weight in your shoulders. It's the band around the base that should, be supporting things up. But topical anti-inflammatory creams, the diclofenac that used to be compounded as a prescription is now available over the counter, and 4 times a day has been shown to decrease mastodynia. I think it's a combination of the direct delivery of the anti-inflammatory, but also the act of massaging the breast to rub it in, which increases the blood flow. In Florida, and I know there's other states as well, massage therapists can be certified in breast massage, and it's a medical massage, and your insurance will pay for it. That does seem to help. But narcotics are not going to help. Oral narcotics are not going to help. NSAIDs kind of sort of help, Advil, Tylenol. But the only FDA approved medication is Danazol. It's effective, but a lot of side effects of weight gain, hot flashes, a lower voice, muscle cramps, hirsutism. It really pulls away the feminine characteristics that you see because it's opposing that in the breast tissue. And women of childbearing age really can't use it because it has effects on the fetus. But I've never had to use Danazol, but it is the only medication with FDA approval for breast pain.
Now, tamoxifen used to be one of our answers as well. How about that?
It's not approved by the FDA. But it has been associated with decreasing mastodemia. And there are some studies where people have looked at it and said that they got better relief of the pain scores with fewer side effects. I mean, we've used tamoxifen for years for lots of things. And so we understand it. We know it very well. But it still just hasn't gotten FDA approval for that. And I haven't had to put anybody on either of those drugs. But if you're getting to the point where the pain is so unbearable and you've really involved multi-faceted pain control, pain specialists, I would say consult with your friendly medical oncologist colleagues and see if tamoxifen or Danazol is something that they'd be willing to try. But the reports say tamoxifen works better, but it's not FDA approved.
Well, you convinced me that it's a vexing problem for all of us. And I will also remember that fibrocystic disease is not to be used. I stand appropriately corrected. It's kind of, you're not supposed to use motor vehicle accident anymore.
They are collisions.
Collisions, you are correct. But anyway, let's get back to talking about some breast diseases. And how about the patient with mastitis? And I'm talking about a young female that is not pregnant, no history of breastfeeding. Her breast is swollen and erythematous. Where does that evaluation start?
These are going to be common. And as a surgeon, we are taught to cut open infection, drain it out, get the evil humors out, so to speak. But it's going to be very common. And it's usually in your pre to perimenopausal women that you're going to see. And you have to remember that it's twofold the reason that they're sending this to you. One is because they've got an infection and they want you to help take care of it. But in the back of our mind, everybody is afraid of that locally advanced or inflammatory breast cancer. Nobody wants to miss that. And so while the majority are not going to be from a cancer, we still have to be very, very critical in our examination and make sure that we're not missing out on this rare but very aggressive presentation of breast cancer. So the first place that I start is on the physical exam, looking at the integrity of the skin. If she's erythematous and the skin is intact, or there may be some, kind of that thinning, shiny skin, which tells you it's just about to, ready for rupture and just ready to blow. But two, the location. Inframammary intertrigo can be very red and confused for mastitis a lot. As breasts get ptotic and there's skin on skin, women don't necessarily wear their bras around all day, and you really can get some inframammary intertrigo, and this is not, it's treated very differently with topical steroids and some cornstarch powder to dry the area, not necessarily antibiotics. As far as imaging in an emergent situation, the first thing that you're going to try to get is ultrasound. And so, like you said, we're talking about ultrasound a lot. I have an ultrasound in the office. And so that would be the first thing that I would do is in that area of erythematous, in that red swollen spot, put the ultrasound on there right then. And I'm looking for a fluid collection.
And if you find that fluid collection, is it still okay to just aspirate it?
Mm-hmm. Yeah. So again, as surgeons, we are excited about incising and draining, but our Choosing Wisely campaign, again, is we really should not routinely operate on a breast abscess. You should initially try to percutaneously aspirate or drain it. So depending on the size, I'll either put a needle and remove the fluid out and drain it, or sometimes I'll leave a little drainage catheter in. There's lots of different sizes that you can just kind of have stay in there. Some are very similar to the like little AngioCast. It's just like a little IV with some holes in the end, and you hook it up to a negative suction bulb and it'll drain that nicely.
What if the ultrasound shows that it's loculated fluid in a cup? There's septi in the mass, or in the cyst, or in the fluid collection, however you want to define it. Does that make a difference?
It does. The aspiration is not always going to be successful. And so having multiple loculations on the ultrasound is one of the things that predicts that it might fail. Very large, greater than 5 centimeters, or if they delay presenting to you more than 6 days after it started, those are going to predict that you may not be able to have success with draining it. I still try to drain it. Cosmetically and pain wise, you get a better outcome, but you're able to get a very good culture when you actually aspirate the fluid sterilely and directly from. I think we've all been involved in some situations where there's somehow a culture of an intact skin with cellulitis, and you don't know where the fluid came from or what it is, but there's going to be skin contaminants, and a lot of us in the healthcare field, depending on what we do and what our exposures are probably walking colonies of MRSA. So we swab this intact skin and get an MRSA culture, and then we've committed them to lots of antibiotics. So even if it's loculated, it's worth trying, and you really should try to aspirate what you can, and then you can target your antimicrobial therapy appropriately based on a good culture that is appropriate.
I'm really glad you've been mentioning the Choosing Wisely campaign, but in that campaign, is there a threshold for when aspiration is not working and you should go to incision and drainage?
There's no absolute number. You should try the aspiration, and you can do it multiple times. There's no consensus on how many times is too much or how much isn't enough. You can leave an indwelling catheter, and you can flush these things. You can flush it with antibiotic irrigation. You can flush it with normal saline, just like we would do with intra-abdominal abscesses or abscesses in other parts of the body. So there's not an absolute number of you've aspirated X times, this needs to go to the operating room. But if you do feel like you need to go to the operating room, so if the patient is not stable, you don't have source control, if this is causing a problem and you have to take them to the operating room, sometimes you just have to. And what you're going to do there is you got to debride all the non-viable tissue. And most of your abscesses are going to be central, right underneath the areolar complex. You want to try to get all of that fistulizing tissue and those ducts debrided out so that you don't have recurrences, because this is a very recurrent problem. Some people will leave it open and then kind of put like a little Penrose drain and packing. That is so painful. It's a very sensitive area. If at all possible, close it over a drain, pull the drain out later. It causes long-term pain and problems.
Let's change the scenario a bit to a breastfeeding patient who develops mastitis. Any difference in your acute management, or still the same?
It's still going to be the same, but you always take a deep breath and try to remember, what can I give a pregnant woman that does or doesn't get in the milk, and what can babies have? So, thank goodness we live in a technical era where you can, quickly look up these medications. But there's really no need for her to pump and dump. She can continue to breastfeed from that breast. You got to make sure that the skin is intact. The pregnant abscesses are usually going to be more peripheral, so you usually don't have a whole lot of skin breakdown around the nipple areolar complex. But if there's open skin around where the baby's going to have contact with breastfeeding, it's really not a good idea because the floor in the baby's mouth is going to get into that open incision, and that creates a whole different problem. And we try to stay away. We can use the topical antibiotic ointments in a non-breastfeeding woman, but in a breastfeeding woman, you really don't want the infant to be exposed to those topical antibiotic creams. So apart from keeping up with what antibiotics you can and can't use. And I just work really closely with my obstetricians and make sure that I'm up to date on that, encouraging the mom to continue to breastfeed if that's what they want to do, and no need to pump and dump.
Well, let's talk about something that is obviously much more common than when I train, that's for sure. But let's talk about breast reconstruction procedures. And I realize they're complex, and I realize that most of the time they're not done by most of our listening audience as general surgeons. But in your opinion, what should we as general surgeons know about the outcomes associated with breast reconstruction?
Yeah, I think that general surgeons have a huge part to play with their reconstruction. It's a whole lot more popular. And when the Women's Health and Cancer Rights Act passed in '98, women became more aware that this is covered by their insurance. It increased awareness, and more patients are seeking this. But as the general surgeon, it's important to understand where you make your incision, is going to affect what reconstruction they can have down the road. So I think that the general surgeons have a big part, to play in this. But the most important thing to remember is that any reconstruction efforts should not delay your surgical treatment. Access to reconstruction and plastic surgeons is a problem. And we can't deny that there are disparities in populations that just can't get that service for them. But national guidelines are very clear that you should not delay the oncologic surgery to coordinate reconstruction. As we work as general surgeons, understanding our team, where we plan our incisions, if they're going to, do a mastopexy and kind of an oncoplastic, where's their pedicle going to be, if they're going to have autologous or their own tissue, if they're going to have implants. But my comment is that delayed will always be better if reconstruction will delay your initial oncologic surgery. Our goal is to get the cancer out. But also, as the surgeon, we have insight into the presentation of the cancer and whether or not radiation might be needed. So if we are doing a mastectomy and we know that radiation after the mastectomy is going to be planned, we really need to delay that reconstruction of an autologous reconstruction. But if it's implant-based, then it would be beneficial to get the implant or tissue expander in before the radiation. So the general surgeon really is the captain of the ship. And even though we're not directly doing the reconstruction, we have a big impact on coordinating that and make sure that's done appropriately and safely.
Are there major differences in the outcomes between autologous and implant-based reconstruction?
There are. The complications with mastectomy after reconstruction are very high, and there's been a lot of studies looking at this because as patients want this more, we have more data. So a patient that has a mastectomy and goes directly to an implant has the highest rate of wound infection, whereas the old-fashioned tram-flaps have the lowest infection rate. We see that patients who have reconstruction are more likely to experience a complication that requires them to be in the hospital if it is an autologous or using their own tissue versus an implant. So implant is less likely to be readmitted. The autologous are more likely to be readmitted. And what's key is that the implants, we worry about infection. And so implant salvage or trying to save implants can become a really difficult process. So if somebody is trying to get through their adjuvant chemo, their immune system is not going to be very strong. And we really have to be mindful that we're not putting how the implant looks ahead of their chemotherapy, which should be, the treatment should be the most important thing. But then pain after surgery is a huge in the reconstruction. The biggest predictor of postoperative pain is something they call the pain burden index, is something that our surgeons will go through. And if they have axillary dissection, which is lymph nodes removed under their arm, that's the biggest predictor that they're going to have pain for a long time afterwards. Women that have the mastectomy, and then they have either the tissue expander or direct to implant, have similar pain scales, use about the same amount of morphine. But it's hard to really pare down what is going to cause the postoperative pain. But what we can generally say is the younger women with a higher BMI, preoperative anxiety and depression are more likely to suffer long-term chronic pain from their reconstruction. it's a confusing bag with that because there's always going to be something that's a small study, but I think we can all agree that the complication rate is higher than if you had no reconstruction, and the pain is going to be higher than if you had no reconstruction.
Okay, which leads me right into the idea of prophylactic mastectomy. And in that patient with average risk for breast cancer, have we really identified any benefit from contralateral mastectomy at the time the breast cancer in the contralateral breast is taken care of?
No. Yeah. The risk of a contralateral breast cancer in the other side, it's very low. I tell patients 0.1% per year, so at 10 years, 1% more. It's a little bit higher than the general population, so it's not zero. A prophylactic mastectomy can decrease the risk of breast cancer, but it's not going to eliminate the risk of contralateral breast cancer. You know, I can't tell you the benefits other than a 95% reduction in breast cancer, but I can tell you some of the unwanted consequences. The cosmetic outcome, studies have shown that their satisfaction is not higher than those that have a unilateral mastectomy with reconstruction. Complication rates are double with the contralateral prophylactic mastectomy. Contralateral perfect mastectomy increases the rates of needing to go back to the operating rooms and increases the rates of minor complications. You may not have to go back to the operating room, but you're going to have more procedures done. And any studies have shown zero impact on survival and disease-free survival. It just doesn't pan out to be a protective mechanism that helps you live longer. I try to explain to my patients that the two breasts are not connected. So worrying about it coming from one to the other is really not the concern. If it spreads to your lymph nodes. And then I give the analogies of colon cancer or skin cancer. If I said you had right-sided colon cancer, you wouldn't ask me to just take the whole thing out just to be sure, because it doesn't eliminate the chance of you ever getting a colon cancer. And sometimes that kind of brings you back in. But the American Society of Breast Surgeons have published a lot of strong statements about, educating on the contralateral prophylactic mastectomy because the complication rate is so high, and that the patient has to understand. And when I tell them that you could still get breast cancer after a bilateral mastectomy, after the look of shock and awe leaves their face, they start reconsidering it.
There's another thing that has happened through CSAP regarding breast cancer, and that is, and I think it's great, that there are now a few methods that we use to adjust chemotherapy and hormonal therapy for patients with breast cancer after their initial treatment. And there's the number of systems has increased. I don't think it's logarithmically, but there's certainly more than there. Each time we do it, there seems to be more. So let me give you a few of these, and can you tell us how they're used? And the first one is the Oncotype DX breast recurrence score.
Yeah, what we're talking about here are gene expression assays or multi-gene panel testing on the genes in the cancer tissue. So it's not gene testing in the patient's native DNA, but the genes that the tumor expresses. And we try to use these to predict the chance of cancer recurrence. The surgery is the cure, but then everything that we do afterwards is trying to prevent the chance of it recurring or come back. And chemo is one of those tools. So we've always tried to find some objective data on who gets chemo and who doesn't. And then as we have gotten more finessed, we've tried to figure out who can we spare from chemo without sparing them from some sort of benefit. And the most recent cancer 8th edition, you have these gene expression assays that are actually in the TNM categories instead of just size and lymph nodes. So the first one, and I think this is the one that most of us know the most about, is the Oncotype DX breast recurrence score. This is a 21 gene assay, and it can be done on paraffin blocks. So it's something that as long as your institution still has the paraffin blocks, and I think most places keep them 7 years or so, you can order this to be done on the tumor. And what they give you is a recurrence score or a number. And that number is categorized. It used to be into these three categories: low, intermediate, and high, less than 18, greater than 30, and they're in the middle. And then Taylor RX took that group in the middle and randomized them to chemo and no chemo to get a better idea of who needed chemo and who didn't. Then they had the RX Bonder trial for node positive, and this one resulted out to say that even if you have up to 3 positive lymph nodes, if you have a score of less than 25, you can skip chemotherapy. But the caveat to this test, and it's important to understand, is that this recurrence score is only valid in the face of 5 years of endocrine therapy. So if a woman says, my oncotype was low, so I'm not going to take my aromatase inhibitor, that's just not sound logic. That number is no longer relevant. It's no longer valid. So one of the difficulties with this is the adherence to aromatase inhibitors and endocrine therapy is very low. In the study, the numbers imply that 5 years is what you have to have.
And what about the MammaPrint? That looks like it's got more genes that we assay.
More is better, yeah. MammaPrint is 70 genes, and it's a microarray, and it's looking at the risk of a distant recurrence at 10 years after surgery. So it's looking at systemic recurrence again. And it's the first genomic assay that was approved by the FDA. So they did get some kind of headway and foot in the door with that. And what they did, instead of trying to figure out who needs chemo, they had the MINDAC trial, which is the microarray in node negative and 1 to 3 positive lymph node disease may avoid chemotherapy trial. And what they were trying to figure out is in both estrogen positive and estrogen negative tumors, which patients fell into this what we call super low risk category that could be spared from chemo with no effect on survival. So it's reliable in predicting prognosis in patients without regard to hormone status, lymph node status, and as opposed to the one we just discussed, it does not imply any kind of baseline treatment in order to be valid. It goes straight off of the tumor array. And so, maybe that's the other 49 genes.
Well, then let's go backwards and let's talk about the breast cancer index, which is also called, I guess, the risk of recurrence and extended endocrine benefit test, which is a 7-gene microassay.
Mm-hmm. Lucky number 7, And this one is different in that it's not really looking at chemo or cytotoxic chemotherapy like the other two. This one is trying to help us guide us in our endocrine therapy. Right now, we recommend 5 years of endocrine therapy, whether it be an aromatase inhibitor or a selective estrogen receptor modulator like tamoxifen or raloxifene. And 5 years is what we've recommended. There were some people looking at, maybe 7.5, 10 years. And it was kind of, let's try, let's see. And so this index with these 7 genes gives you objective data that after 5 years, would you benefit from 5 more years of extending that AI therapy? And in those patients that had a high score would benefit, they showed a 15 to 20% reduction in the recurrent risk and a 2 to 4% improvement in disease-free survival. So it's predicting the likelihood of a late recurrence and determining the likelihood that you would benefit from 10 years instead of 5 years. But this one is only in estrogen positive and lymph node negative breast cancers. And as we talked about already, the adherence with 5 years can be low. We don't order this BCI or the breast cancer index until that 5th year, because if somebody has already dropped off and they're not going to take the recommended 5 years, having another objective test to say, you should have done 5 years, but also you should have done 10 years, really doesn't give you a whole lot of useful patient interaction. But if they're doing fine on 5 years, you can test, and then if they want to be aggressive and it shows that that's supported, then you can continue it. But those that want to be aggressive and doing everything that's possible, you can show them that, for you and your genetic array, 5 years is sufficient. You did your duty. Good job.
And then I'm going to assume, since you said you're going to try this after 5 years, that this can be done on a paraffin block tissue?
Yeah, it can.
Oh, okay. All right. And then finally, there's one more. It's called the PAM50 or the Prosigna breast cancer prognosis gene signature assay.
And I guess this one's in the middle. We had 2170 and now 50. It's another microarray, and it reports a risk of recurrence score, or a ROR. And you get this, again, similar to the Oncotype, a continuous variable. And then it is put into categories of low, intermediate, and high. It has been retrospectively validated in postmenopausal women for estrogen positive tumors in both lymph node positive and lymph node negative. We have a lot of Prosigna here in Florida, but prior to moving to Florida, it was one that I had only really read about. So some of these assays may be regional and institution specific, but they all have a different question that they seem to be answering in a different population base that they're appropriate for.
So yeah, I think you've answered my question. My next question was going to be are we using these on every patient, all of them at various times to make some decisions, or is this sort of local politics instead of federal politics?
No, it's really, that's a good way to ask that question. But one of the utilities that I saw for this, and I really wouldn't have predicted this until it happened, but during the pandemic, we really had to triage our upfront surgical candidates. We were limited on equipment for the operating room. We were limited on staff. So triaging these surgical patients into who needed upfront surgery versus who could possibly have neoadjuvant chemo became important. And so we came together as a community here and developed a protocol for a combination of the assays, depending on if they were clinically node positive, clinically node negative, estrogen positive or negative, on running these genomic microarrays to find out, okay, this woman, is not going to have a favorable response, we think, to neoadjuvant, so let's use the supplies we have in the operating room to take her to surgery. Or, this one would get a good response, let's save our surgical expenditures and go ahead and get her into chemo first. I think you're going to see these evolve and be used in different situations. But there's a few groups that did what we did here locally, and they're collecting long-term data, and I'll be interested to see if that use of these assays, as we hadn't usually used because we haven't had a pandemic and while they existed, how that affected our outcomes and what's that's going to mean. So there's a lot of really, really neat, useful information in there. We just have to learn what it means and how to use it.
Okay, let's move on to another topic that is also much more visible in CSAP 18 than it's been before, and that is neoadjuvant chemotherapy in patients with breast cancer. And I have a crystal ball question for you, Charlie Gale, and I have watched, and CSAP 18 has proven it, that in pancreatic cancer, we have moved almost to where everybody is getting neoadjuvant chemotherapy, even in stage 1 disease, because of its beneficial effect on, at least in pancreatic cancer, is survival. And so I would ask you, with your crystal ball, is this a movement that is going to occur in breast cancer as well? And what really do we expect in breast cancer to be the real benefit of neoadjuvant chemotherapy?
I have watched the pendulum swing in neoadjuvant chemo in my training. Again, as a surgeon, we have a surgical problem in front of us. Our impetus is, let's get the surgery and then we'll send them over to oncology. And so in my training, it was really, really emphasized to me that neoadjuvant chemo is important. It doesn't change the survival, but it can downstage a mastectomy to a lumpectomy. It can downstage a clinically positive axilla, requiring less axillary lymphadenectomies and less resulting lymphedema. But it also allows us to monitor the biological response to the proposed regimen. So if we find that somebody completes their entire chemo and then we do surgery and there's absolutely no response, then we look for a clone. There's a more dominant clone that was more important. Whereas adjuvant chemo, you give the regimen, hope for the best, and then hope that that was the right one. I am seeing though now that in these what we call luminal A's or estrogen positive, HER2 negative, node negative, and even some node positives, that the oncologists feel like, this still isn't aggressive enough that chemo is going to have a huge impact. Let's just go and have upfront surgery. Now, in triple negative and HER2 positive, different story. I think all of those are going to, be tried to get some sort of neoadjuvant chemo, because the one cancer, HER2 positive, that gets neoadjuvant chemo, there is a survival advantage. The others haven't shown a survival advantage, but HER2 positive has with the monoclonal antibodies that we now have with hertuzumab and pertuzumab. So I've seen the pendulum swinging back to try to get everybody neoadjuvant chemo to there's going to be select biological subtypes that absolutely benefit from neoadjuvant chemo.
So a little different story in breast cancer than seems to be going on in pancreatic cancer.
Yeah, I think so.
All right. Well, then, obviously, when you give somebody neoadjuvant chemotherapy, they're immunosuppressed. And has there been any real recommendations for how long you wait for your surgical procedure for your breast cancer after your neoadjuvant chemotherapy is completed?
There is. And this is another reason that surgeons are less than excited to put their patients through chemo before they operate. I remember when we were using Avastin in breast cancer patients, and the wound healing was so impaired that you kind of dreaded the surgery date because you were going to have a dehiscence of some sort of wound. But the timing of surgery is key. You want to make sure that they have recovered from their chemotherapy-induced neutropenia so that they're strong enough to heal from the surgery, not get an infection. You want their white count to be high enough they don't get an infection. You want their platelets high enough so that they can form scabs and clot. And you want their hemoglobin to be high enough that they can deliver enough oxygen to their heart and brain while they're healing this wound and not have a cardiac problem. 14 to 21 days is usually what I wait. Anything that's after 4 to 6 weeks is really going to be too long. And if you wait more than 6 weeks, you're going to have a survival deficit and you're going to impact survival. We talked about these targeted medications. So trastuzumab, which is used in the HER2 positive population, does have some cardiotoxic side effects and can decrease your left ventricle ejection fraction. So they get a baseline echo and then it's monitored. So if your patient is ready for surgery and she's been on trastuzumab, you need to look at their last echo, because if their ejection fraction is low and it's going down, you might need to delay surgery, or, cardiology may need to be involved. They may need to hold their next dose. So optimizing these patients can be tricky.
Charlotte Gale, I cannot tell you how much I appreciate you spending time with me today. I would remind our listeners that I find your explanations through the CSAP process that I've listened to quite a bit. I'm not a neophyte at that. And you always have very crisp, clear explanations, and you've done it again today. So I thank you very much for that.
Well, thank you for including me.
Well, it's my pleasure, and I guess you have the last say on this. So you are invited to say anything you'd like about the CSAP process. It's not a paid political announcement, and please be as transparent and as honest as you want to be.
I used the CSAP when I was a resident, and I remember how helpful it was. And now being on the other side of it, I see the opportunity to help other people in that position. And I know how much it helped me. But, my mentor, Dr. Gabram, was a part of this. And when I was her fellow, watching her go through and what she learned and how it stretched her to learn more, inspired me to kind of throw my hat in the ring. And I was lucky when my hat got pulled out and my number got called. And it's been a lot of fun. And I've stretched myself and learned a lot more. So I think I'm a better surgeon for it. So I appreciate the efforts that you continue to put into doing this. There are some thankless jobs and this is a lot of work. So I appreciate you sticking in there.
Well, thank you very much. And I actually got to see Cheryl, who's an old buddy of mine.
You can't call women old.
I'm sorry, an effervescent,
There you
how
go.
about that, young lady. And at the clinical congress this last year, which obviously we met face to face, which is a unique experience after 2 years being apart. But it was good to see Cheryl, and we had some good conversation. And I really thanked her. I thanked her many times for sending you my way. So. I hope you and your girls have a wonderful Christmas holiday, and hopefully you avoid any hurricanes. Okay.
All right. Well, you've got an open invitation to ride out the next hurricane with us.
Okay. I'll put that under consideration.
Thank you, Dr. Weigelt.
Thank you, Charlotte Gale.
Of course.